The topic is, does radiation favor radical prostatectomy in long-term quality of life? And this is a tough topic, mainly because of the sparsity of comparative data. Oops. These are my disclosures. So just some background issues here. Non-lethal prostate cancer is increasingly managed with surveillance. Potentially lethal prostate cancer generally requires multimodality treatment, and that can be surgery plus or minus radiation plus or minus ADT, or a radiation-based approach would be radiation plus ADT plus or minus brachytherapy. And the quality of life is going to depend on the combination of modalities used and the timing of the modalities. Patient-reported outcomes are unfortunately quite rare, and there's a variety of instruments available. So what I'm going to go through here is the level 1 evidence from PROTECT, the origins of tri-modality treatment, the level 1 evidence from the ASCENDE-RT trial, and then a prospective database which compares modalities. So you all know about the PROTECT trial, which was reported in the New England Journal in 2016. Prospective randomized trial of surgery, radiation, and active monitoring ran from 1999 to 2009. 1,600 men with screen-detected prostate cancer. 3/4 of them were Gleason 6. 3/4 of them were T1C. The median PSA was 4.5. The radiation delivered, appropriate for the time, for the era, was 74 gray and 37 fractions, and they all had 3 to 6 months of androgen deprivation. 55% of the active monitoring patients ended up being treated. So these show the results. The prostate cancer-specific mortality, as you would expect in this group of patients, was very low, less than 1 per 1,000 patient years. Distant metastases were more than twice as common in the active monitoring arm compared to radical prostatectomy or radiotherapy, and disease progression also was more than twice as common in the active monitoring arm compared to radiation and surgery, and those were equivalent. This shows prostate cancer-specific survival, absolutely no difference amongst the 3 arms. This shows freedom from disease progression. External beam and surgery are completely overlying each other here, where active monitoring is showing a toll of disease progression. The quality of life aspect of this trial was reported the same year by Donovan, and they reported this at a 5-year follow-up. For the urinary domain, they used the EPIC and the International Consultation on Incontinence questionnaire. Sexual and bowel domains were both the EPIC instrument, and health-related quality of life used the short form 12, the Hospital Anxiety and Depression Scale, and the EORTC questionnaire. So these results are not really a surprise to anybody. Surgery had the greatest effect on sexual function and incontinence. This remained worse throughout the entire follow-up period. External beam, sexual function was worse at 6 months, but all these people had ADT, and then there was some recovery. And in the active monitoring arm, of course, both sexual function and urinary function both steadily decreased over time. And sadly, that is just what happens. In the graphs here, surgery is in red, so this is the incontinence score, and you see incontinence, major problem at 6 months with improvement and then holding steady. This is use of pads, so big problem at 6 months, improvement up to 24 months, and then holding steady. For sexual function, big drop with surgery, some improvement, but stays lower than the other modalities. Radiation, big drop with the use of hormones, some improvement, doesn't get back up to the level of the active monitoring group, but then declines at the same rate according to age, and active monitoring is just a steady downhill course with time. In terms of bowel function, it was worst in the radiation patients at 6 months, but it did recover. Hematochezia, or blood in the bowel movements, continued to be a problem though. However, bowel bother and incontinence did recover and ended up being the same in all modalities. So you can see here the bowel bother score with radiation is worse at 6 months, but then recovers. And in terms of having blood in the bowel movements, that increased up to 24 months and then stayed at a pretty steady state. Fairly low incidence, but still different from the other modalities. But this was 74 gray with a short course of ADT in a category of patients, mostly whom we would not even treat now. So let's go into the multimodality real world. And I want to talk about the origins of tri-modality treatment. This was an article authored by Dr. Stone back in 2009, looking at the effect of a high biologically equivalent dose on outcome for Gleason 7 to 10 prostate cancer treated with brachytherapy. Now, this isn't the Mount Sinai results. This is a multi-center study with a median follow-up of about 4 years. Over 1,000 patients treated with LDR brachytherapy, but 80% were Gleason 7, 20% Gleason 8 to 10. About 60% had hormonal treatment, short course, median duration 4 months, and 60% had external beam. The important thing to note here that when you added external beam to the brachytherapy, the median biologically equivalent dose was 209 gray. So it's getting into the range of what we need to see. Versus if they had brachytherapy alone, it was 155 gray. And if you look at the dose groups less than 200, 200, 220, over 220, you see that in the higher dose groups, 5-year freedom from biochemical failure, it definitely favors a BED over 200. And this is even more prominent in Gleason score 8 to 10, where it was 86 to 90% versus 52% for the lower dose group. However, even with the high biologically equivalent dose over 220, you still need ADT for Gleason score 8 to 10. The 5-year freedom from biochemical failure was 96% with ADT versus 78% without. And there were also implications for distant metastatic freedom. So this is not that report, because the ASCEND trial started earlier, but the whole experience and the protocol that was being used in New York was the impetus for starting the Canadian trial, the Canadian randomized trial, ASCENDE-RT. ASCEND stands for androgen suppression combined with elective nodal dose-escalated radiotherapy. We've seen the schema before. 400 men with high-risk disease, 2/3 of them were high risk, or high-tier intermediate risk, all received 1 year of androgen deprivation. They all received pelvic radiation, 46 gray and 23, and the randomization was between having a brachytherapy boost to an additional 115 gray with iodine versus continuing the external beam to a total dose of 78 gray. And this shows the difference in biochemical progression-free survival for all patients. The arm that had the brachytherapy boost is up here, and 78 gray is here. The difference at 9 years using a Nader +2 definition is 83% progression-free survival with the brachytherapy boost versus 62% for the 78 gray. Now, if we just look at the high-risk patients, is what we're dealing with here, at 9 years, it's 78% disease-free if they had a brachytherapy boost versus 58% for 78 gray. So remember those numbers because we're going to come back to them. What about the ASCEND morbidity? Well, I would maintain that the greatest morbidity seen in this trial was randomization to 78 gray, causing twice the risk of biochemical failure at 6 years. Quality of life data was not collected after failure, so the toxicity of salvage is not considered when comparing the two arms. However, the 5-year cumulative grade 3 GU toxicity was 18% with brachytherapy versus 5% for 78 gray. The prevalence, because most of these issues were dealt with a couple of dilatations, they resolved. The prevalence of grade 3 GU toxicity was 8% versus 2% at 5 years, and actually at 6 years it's down to 6%. 5-year prevalence of grade 3 GI toxicity was similar, and 5-year sexual function that was similar to the baseline was actually better in the brachytherapy patients, 45% versus 37% for 78 gray. Now the problem with the toxicity, like if you treat someone and their cancer comes back, you say, well, I did my best, it's cancer, no one's going to sue you. If you treat someone and they get grade 3 toxicity, you could end up in court. And I think people are much more afraid of toxicity when they're delivering treatment than the failure of their treatment. If we look at patient-reported outcomes, because what I previously presented, well, the last bit was all from just grading the events, patient-reported outcomes were also collected using the SF-36 for urinary, bowel, and sexual function. When you're using this instrument, a decline of over 10 points in the score is considered clinically significant. It was evaluated every 4 months for a year, then every 6 months for 4 years, and then annually with high compliance, 82 to 95%. However, again, nothing was collected after failure. At 12 months, there's a much larger drop in the mean scores for the brachytherapy group than the 78 gray group. But 12 months in this trial was only 6 weeks after their implant, because all these men had 8 months of androgen deprivation before starting their external beam, and the brachytherapy followed the external beam 2 to 3 weeks later. At 6 years, sexual function and urinary function were still slightly worse for the brachytherapy arm. Everything else was similar. So this shows the scores. Anything that was over a 10-point difference is in red, and you can see that at 6 weeks after brachytherapy, physical function, vitality, physical role is taking a hit, but you kind of expect that. By 5 years, it had all evened out. These are just in red because it's just over a 10-point difference. And this shows how physical function or physical role changed over time. The blue arm is the 78 gray, sort of up and down as expected. Red is the brachytherapy group right after their implant, then improving, and then just sort of meandering along with the 78 gray arm. Similar curves here for urinary function, bowel function, and sexual function. Now, interestingly, for the patient-reported outcomes, the 78 gray arm appears better than the brachytherapy arm, and it was the reverse when there was a recording of sexual function according to the IIEF questionnaires. So that gives a bit of background. So let's bring radical prostatectomy back into the discussion now. And I want to focus here on a report from the Cleveland Clinic published by Jay Ciezki last year, comparing outcomes for high-risk prostate cancer using either brachytherapy with or without ADT. And this is brachytherapy alone. It's not with external beam. So brachy plus or minus ADT, external beam plus or minus ADT, or radical prostatectomy plus or minus external beam. So they have a prospective database at the Cleveland Clinic. They took patients treated from 1996 to 2012, 2,500 of them, median follow-ups over 5 years. Over 700 had external beam with ADT, and 90% of these guys got ADT. The external beam was modern fractionation, either 78 gray and 39 fractions or 70 and 28, which is considered equivalent. Surgery was radical prostatectomy in 1,300 patients. About half of them were open, 36% were robot-assisted, and 18% of these men ended up getting external beam after their surgery. And then the brachytherapy was 500 patients. About a third had some ADT. And the 30-day D90 for these brachytherapy patients was 149 gray. And if you remember back to the Stone article, with brachytherapy alone for the high-risk patients, they had a D90 of 155 gray. So it's in the same ballpark. Baseline characteristics of these patients, the follow-up is longer in the external beam group. The brachytherapy and prostatectomy are about the same. Interestingly, the brachytherapy patients were older. The external beam had a higher percentage of PSA over 20 and T3 disease, but the brachytherapy and prostatectomy patients were pretty balanced. About 45% had 2 intermediate risk factors and 1 or more high risk factors in just over 50%. So this is a really quite balanced group here between brachytherapy and prostatectomy. We're going to look at that later in a table. If you look at prostate cancer-specific mortality by treatment, green is the external beam, red is radical prostatectomy, and blue is brachytherapy. And these differences are statistically significant. If we look at whether ADT made a difference for the patients getting brachytherapy, and again, this was about not quite 1/3, 2/3, more than that. 240 got brachy alone, 374 got some ADT. It made no difference, which I find a little bit surprising for this, but maybe ADT doesn't isn't synergistic for brachy the way it is for external beam. But anyway, if we look at the toxicity now, grade 3 GU toxicity by treatment, prostatectomy in red, external beam in green, and as we often see with GU toxicity after radiation, this doesn't plateau. It just keeps steadily going up and up and up and up, and by the time you get to 15 years, it's equivalent to what was seen in the prostatectomy group. And brachytherapy is at a slightly lower level. If you look at greater than or equal to grade 2 GU toxicity, you see something very similar: prostatectomy, external beam steadily increasing, and brachytherapy. If we look at greater than or equal to grade 2 GI toxicity, external beam is definitely the worst of the three, whereas prostatectomy and brachytherapy are pretty much equivalent. Cumulative second malignancies, external beam wins again as expected. Brachytherapy and surgery are overlying. So if we look at the efficacy results now, first of all, we've got external beam, brachy, and radical prostatectomy, 5 years and 10 years. I put these in red, but I don't think the difference is really is significant. I think it's just an artifact of earlier detection of failure in the prostatectomy group. So you're calling a failure earlier as soon as the PSA starts to rise, whereas in the radiation modalities, you're waiting till it gets to nadir +2, because they're pretty similar. If we look at prostate cancer specific mortality, at 5 years, external beam's a bit higher, brachytherapy and radical prostatectomy, very similar. At 10 years, external beam continues to increase, it's up to 11%. Brachytherapy is 3.5%, radical prostatectomy 6.8%. 10-year greater than or equal to grade 3 GU toxicity, radical prostatectomy comes out the worst. External beam doesn't get there for another 5 years. And 10-year grade 3 GI toxicity, of course, external beam is the highest at about 5%, with brachy and radical prostatectomy at 1%. So I found this really fascinating because they've had this prospective database and they've collected all this toxicity data. It's not randomized. Brachytherapy group is a shorter follow-up. Few of them are beyond 10 years. Brachytherapy alone is hardly ever considered for a high-risk disease. The other interesting thing that was borne out here is that the GU toxicity for external beam doesn't plateau and equals that of radical prostatectomy by 15 years. But brachytherapy appears to be an ablative treatment equivalent to radical prostatectomy without as high a price of incontinence and sexual dysfunction for the patients. Brachytherapy alone can't do better than radical prostatectomy alone for high-risk disease. So that's another point that's brought out in this comparison. I think for optimal results, we need the combination of ADT and external beam with brachytherapy. If we're going to change that 50% disease-free rate at 10 years up to the 78% that we saw in ASCEND, we have to accept that. And when we're looking at toxicities versus failure, all those patients, this is high-risk disease, so all those patients who fail are doomed, Dan's left the room, are doomed to go through that sequence of all this aggressive second line, third line, fourth line treatment, and you can't tell me the quality of life associated with that is very good. So tri-modality, ADT and external beam and brachy, is the most effective form of treatment for high-risk prostate cancer. If you add external beam to brachy, you are going to increase some bowel and GU effects, and we saw that in ASCEND, or at least with the GU. Tri-modality may indeed have a toxicity price, I'm sure it does, but 5 to 8% persistent grade 3 GU with standard techniques is still quite acceptable when you consider the adverse effects of failure and the subsequent treatments. And I also believe that we can improve that toxicity profile with improved technique, attention to sagittal imaging. I don't think it's a difference between MIC and pre-planning. I think it's looking at what you're doing and where you're putting your seeds and watching on the sagittal. MR planning can help, as Stephen Frank is very keen on. MR quality assurance, which I've been doing for 15 years, which helps you refine your technique and improve. And perhaps HDR, which may have a better toxicity profile than seed implants. Thank you.